That was very interesting. Thank you, Mr. Chairman. Well, thanks to the four of you for coming today. And I'd like to listen to what you have to say, so I'll ask a question that I'll ask each of you to answer. If you could think of one thing that the federal government, that we could do to make it easier for you to spend the money we now spend more effectively, the money we spend primarily through the two big block grants and through Medicaid is the way I gather it's most of the federal money goes to mental health. What would be the one thing that we could do that might make it easier for you to do that? And Dr. Vero, if you could start, and I'd like to ask you this additional question. You mentioned about the importance of a continuum, which makes sense for a community mental health center. Now, you're one of the largest operators of community mental health centers. Would that be an additional cost to each community mental health center if it did that? And if so, who'd pay for that? Would that, if the federal government were to require that, how much would it cost and how much money would we have to appropriate for that? Or if we require it without paying for it, which is sometimes what we do around here, then who would pay for it?
Senator, I want to first start with an acknowledgement of my early service in Tennessee and you in your governor role. We talk about this continuum of care over the age span. When you were governor of Tennessee, we built out a statewide therapeutic preschool program. We had therapeutic preschools in every single one of our community mental health centers across all 95 counties. Those schools were there to deal with their most vulnerable children with whom we were seeing early indications of the onset of severe mental illnesses. Those SED children we've referenced several times today. So what happened? Very few of those programs exist. And I can tell you we are so fortunate at Centerstone to still continue that program, but it's not in the four-wall classroom any longer because that model was no longer affordable. Community mental health care has been subjected to a horrid state of commoditization. It's just a fact. As we move from Medicaid programs to managed Medicaid programs, we are part of the healthcare system that continues to be looked at as a commodity. Our services are minimized oftentimes to their smallest view, to the nickel, to the dollar, to the quarter, to the nickel for differences in choosing who the provider might be, where the contract is, more importantly, what the service is, what that array of services are. So as that requirement dropped with that commoditization, those preschool programs were lost. We took our preschool program and moved it into the community. And here's the good news. We were only able to serve about 48 of those children a year because it was a high-cost program and because the managed care company had a hard time understanding what its role was in addressing the health care needs of these children while they were also receiving vital educational services. So one of the things we need to do from that federal level is let's remove these barriers that oftentimes don't allow us to bring our systems together, education, criminal justice, mental health, in a cooperative way for the sole purpose of addressing our health care crisis. We spent too long arguing over what part of the day education should pay for versus what part of the day the managed care company or Medicaid should be paying for. We have to address those conversations immediately if we're going to make any difference in the conversation that we're having today.
That would be, I'd like to work with you, and I'll ask my staff to follow up to get specific examples how to do that. Just out of curiosity, was that part of the Healthy Children Initiative that we had in Tennessee back then?
Yes, sir.
Well, I'll tell my wife.
She'll be, yeah. Yes.
That was 30 years ago, so we have my wife was the head of that, and the deputy of that was Marguerite Salih, who later, who runs America's Promise until recently, and headed Bright Horizons, the worksite daycare company. Now, my time's about up, but if there's one thing that we could do that would change existing law or practice to spend the money we now spend better, and you can follow that up in writing if you'd like to. Is there one thing you'd like to briefly mention? And that's my last question.
I'd like to make a recommendation that you allow that the services that you currently pay for could be opened up to provide more services at the front end, to provide more prevention, early intervention, support peer services like what Larry was talking about a little while ago, and to let the creativity of this country and how we're moving forward in other areas of healthcare to also enter into behavioral health care and allow us to do the right thing.
Thank you.
You want anything else?
Was there any other comment on that?
Any other comment on this?
Yes, Senator, if I could add to that, we keep talking about access. We've talked about the shortage of psychiatrists, especially child and adolescent psychiatrists. We've been providing telepsychiatry services since 2002 in the state of Tennessee. Those services are getting out to counties where we can't hire physicians, where we can't draw those physicians to maybe those more rural areas. It is 2014 as we sit here today. We need to align our payment streams with our current technology. We're not permitted in the state of Tennessee, and I know elsewhere throughout the country, to provide telecounseling services. I can provide telepsychiatry. I can have a psychiatrist talk to a child and interview that child and provide services and work alongside a practitioner who's sitting next to a child and do medication management. But I can't provide counseling services remotely through telehealth and get reimbursed. It's 2014. We have 12 years of experience on the psychiatry side, and we can't seem to move out of the current limitations around those services.
Thank you, Mr. Chairman.
Thank you, Senator Alexander.